And may I invite our next speaker, which is Professor Michael Huepfl from Vienna. He's one of the eminent surgical intensive care in Vienna, talking to us about hot topics in trauma. Thank you.
Dear chairpersons, dear colleagues, dear faculty of the university here, I'm really honored to be here. I'm honored to be invited. I'm really impressed from your department, the big department. I'm really impressed about this wonderful conference. And when I came to Egypt, I was really impressed by the traffic I saw here. And this is a very good link to my topic that I should talk about, and that is hot topics in trauma. So coming from a cool country, 5 degrees I called today, I'm here in the hot and try to talk a little bit about the hot topics, and I picked out only some. There are many hot topics, and I think that's the big challenge we have here. If we stand up here and we should tell you everything that's wow in our topic. Yeah, a conflict of interest. There is one. I'm coming from the Medical University of Vienna. I'm allowed to work there, do all the cool stuff and have quite some fun in work, and they still pay me money. Yeah? So, and on the other side, I'm also working for the European trauma course, organizing courses, doing courses, directing courses, and they do not pay me money, but still I'm an enthusiast of those. So you have to take this in account when you listen to me, that this is my personal bias here. So, I'll talk a little bit about the background, then the hot topics, and then let's summarize. The background. Background of trauma. As I said, I was impressed by the traffic. Yesterday, I went around with some friends, and when I tried to cross the street, I wouldn't have crossed the street if those two won't have been with me. They always said, "Oh, don't care. That's normal. That's normal. Nothing happens. Everything okay here." Yeah, but let's look at the facts. The facts are that death is still the leading, trauma is still the leading cause for death in the young. Up to age 44, that's the leading cause. Now you would say, yeah, that's US data. Yeah, but everybody in the whole world is catching up to this data, and as we already mastered infections, this is also #1 cause of death here. And these are Egyptian data from an upper Egyptian university about what causes the death, and that is the transport. They didn't look if it's the crossing of the street, Mana. It's maybe only the transport that does it. Then it's falls, and violence is not that big number. So it matters. And we have problems that are system-driven. Yeah, rush hour in Cairo can make some things, and okay, I remember. That's cool. It does not. That's not so dangerous. But let's look what are the main causes why these people die. And there is a meta-analysis, and this meta-analysis focused on it. Why do they die? Quite a lot of brain injury, hemorrhage, and then it's thorax injury or the late injuries when they are in multi-organ failure. So these big parts contribute that you die from trauma. And that's what I also want to focus on a little bit later. So you all already know these three modal state of why or when they die. If they have real fatal injuries, it's over after some minutes. Then I think that's the part where we can really do our interventions. That's in the first hours, and there it depends also a little bit on us that we manage it good. And then there are the late ones with the multi-organ failure, the infections, and all these things coming up after that. I had to pick up some of the data and not all. You see how many publications about, and that was only the search term polytrauma, have been from the last years, and we are on some hundreds every year. And as you see, the last column is 2017. We are catching up and will be better than last year with publications about polytrauma. So let's go to the hot topics. I focused a little bit on some guidelines. There are two more or less up-to-date guidelines. One are the NICE guidelines for major trauma. And these NICE guidelines are nice. Yeah, they have a good website, and there you can go through quite a lot of these topics and focus on them, and they tell you very interactively how to deal with it. And the second one, that's something I think it's not that easy for you, that are the German guidelines, but they are really up to date. And these two, where I picked out some of the things we are talking about now. Trauma and the first letters of the alphabet are usually linked together. It's all about this A, B, C, D, E in the beginning. And when I told you I'm one of these European trauma course guys, that's the same that my friends from the ATLS group says. It's A, B, C, D, E. Let's focus on that. Let's focus what are these elements. When we start with A, we have talked about A on this whole conference quite a lot. Airway, airway, airway. We are the specialists, and there are not many new things, important things in there that are not reflected in our guidelines for difficult airways in any case now. So the A is something that's our routine. But what all these guidelines tell us is, they tell us, get the specialist. Don't let the young go there with a polytraumatized patient. Don't let the one who does not do airway management so often do the airway management in a polytraumatized. Let's get the specialists. That's the message of the guidelines around airway. And airway and spinal cord immobilization, that are the things here. But as we said before, it's quite about hemorrhage and also thorax trauma, and the B is already the second one, thorax trauma, and usually it's a question, how do we detect the pneumothorax? How do we detect pneumothorax and, of course, then the tension pneumothorax? Our classical approach with clinical examination is still good. In the hospital, we do the X-ray, but we have some concerns that it is really powerful. And here it comes from FAST, the focused abdominal sonography for trauma, we developed to eFAST, the extended one. So I saw some excellent workshops here. I heard some excellent talks yesterday about sonography, and I think that's something that we really have to focus on, that we go a little bit higher than the umbilicus with our sonography, and we can have a look on the heart, and we can have a look on the lungs, and we will detect a pneumothorax better than we would do it with an X-ray. So this is one of the big messages. Take the sonography, use it for trauma, and do not use it only for the abdomen, but also use it for the thorax to get see and spot that pneumothorax is. We are even going one step further and bringing it to the pre-hospital setting. In the pre-hospital setting, and we have some studies here that tell us that makes a change in the treatment of the patient. Having an extended focused assessment of trauma with sonography makes a change. Yeah, here we are at the B, the thorax, the chest drain. A standard procedure, we would say. And the discussion about is how big should the chest tubes be, or how small should it be. One study says, oh, you can also do it with small ones. Others says bigger ones are better ones. I think the main point is do it. Do it and don't wait in a trauma setting, because this thorax trauma is one of the real fatal injuries people have. Another thing is a little bit the safety, and as we are here anesthetists and not so good like our surgical partners with sharp things, they looked at how is it doing it with this chest drain with the trocar or without the trocar, and they said, they did it on cadaver studies, and they said, look, the cadavers were in better shape if you do it without the trocar than if you do it with the trocar. So another safety issue, another safety information for us. So we have the A, we have the B, and then there was something in 2015 when the big resource councils gave us an algorithm for the traumatic cardiac arrest. This algorithm for traumatic cardiac arrest was very different to the algorithm we had now. It said very quick, please, if you have, especially in penetrating trauma, if you have a traumatic cardiac arrest, open bilateral with a mini thoracostomy the thorax to get the tension out of it, because this is one of the main reasons for a traumatic cardiac arrest. So that was a big, big signal. But then there was even more. And now we are touching one of the central points we have. I'm pretty sure you, my colleagues, you asked yourself quite a lot, what is the best way to reach my man's heart? And I can tell you, the best way to reach your man's heart is fifth intercostal space, medioclavicular with a sharp scalpel. Then you're at the heart of a man. And this is something we are talking about. We are talking about clamshell. If we have done the bilateral thoracostomy, then clamshell should be. And what's this clamshell? I was not so aware what clamshell is really the word about. And then I looked it up in Google, and clamshells that are these little mobile phones that are doing like that. And that's what this word is coming from for this procedure. And it makes, how do we access the thorax? How do we access the heart? And what for do we need it? It's mostly commentated for penetrating trauma. We can use it if there is the doubt, or maybe with our ultrasound we already saw a pericardial tamponade or a major bleeding. And we can also do a direct open massage of the heart. How do we do it? It's, as I said, fifth intercostal space, and then on both sides, and then a cut on completely on the other side. That's clamshell. So we need to do this technique. We need to have seen that technique. And when I was at the consensus conference in Prague of the Research Council, there was a big audience. I think we were 2,000 to 3,000 people, and they asked, who has seen it before, such a clamshell? And then hands raised, I think about 10 of these 3,000. And then they asked, who has done it? And no hand raised. So we need to be aware of it, that we need to know the technique, that we need to train the technique. We need to know what approach do we really want. But, and I have to confess, I did it once. But you have to ask yourself, what then? Can I stop the problem? Can I solve the problem even if I see it then or not? If you can, do it. If you cannot, you need to get somewhere where somebody is who can. So we're talking quite a lot about this clamshell, and you see that's something that's a little bit emotional, because we do not have a lot of experience with that. And then we have also some studies about it. And the one study said, let's look, maybe we should only open one side. But then they saw, you can do it, but it's a much better approach, and then you will succeed more if you do a complete clamshell. And the other anatomic study also looked at different approaches to do it. So clamshell is the state of the art for doing this in traumatic cardiac arrest. So this has been now the real big thing. But there is another thing that's not that dramatic, but still something that has a potential to stop bleeding. And as we said in the beginning, hemorrhage is one of these big things, one of these, the problem here. We need to stop hemorrhage. And there is this resuscitative endovascular balloon obstruction of the aorta. That's something where the technique is something we are familiar with. It's a Seldinger technique. Yeah? You puncture a big artery, and then via Seldinger technique you put in a wire, and then this balloon in there, and this balloon is inflated in the aorta, and it can be on different positions in there. There are the first studies, there are the first meta-analyses who are in favor of REBOA, that's the abbreviation for that, but still we need additional data. It shows a favor of REBOA against clamshell and open, and it also shows that it is possible. But, and also those who have done it several times say, you also need practice for that, you also need training for that, and if you can do an arterial puncture in a patient with a good blood pressure, that does not mean that this is so easy with a patient under resuscitation. So that are these big, big, big things in what can we do. And I want to add something that's not from the guidelines. I confess, it's not from the guidelines. I found a study where the Germans had a look on their death poll. They had a look from over 21 years how their death in traffic accidents developed. And here you see this one line going up, that's the accidents they have. And then you see this line going down, that are the fatalities they have. And that's not corresponding. And it's not the reason that the Germans became harder and more robust in that time. No, there must be other reasons. And they had a look and they saw what were the interventions. What were the interventions that were done in that time? And only these interventions are medical ones. So not because we are better, but that there have been quite a lot of other things, other interventions that made the death toll going down. And that were things like fasten your seatbelt. Also in the second row. Yeah? It's quite a challenge to find not only the seatbelt, but this second part in the U-bus here. Yeah? I was told that they are not meant for using it. We had other things like helmets. Everybody who is driving a motorcycle has to wear a helmet. Then we had another drop when we had these pediatric seats for the kids, and they have to be in there. Huh? We had a first drop when we said you have to use them. Then it went up again because they saw they were not fined by the police, so they didn't use it. Then the police took money if you don't use it. Then death toll of children went down again. Yeah? Then some rules and regulations in how fast are you going, and also execution for that. And that made the death toll going down, really going down. That's the curve of Austria. In 1972, we had about 3,000 fatalities a year. We are a small country, yeah? And now we are at about 400 a year. And it's this thing, and we can be really good doctors, we can be really good emergency physicians, we can be happy in working in trauma, but we will never meet the expectations of our patients, of the society, because people come, they are crashed, and they want us to fix it, right? That's what they want. And they expect that we will fix it. But the thing is, we can't do it. And I think the point is, now it's on you. It's on you to speak up and tell the people, look, we try hard, we do good medicine, but it will only become better if we have some of the rules, some of the things, some implementations, and then we have the example, it can work. So, to summarize, we talked a little bit about the background, why we are talking about trauma. We talked about the threats that trauma has, and the hot topics about breathing and circulation, traumatic cardiac arrest, the diagnostics with the ultrasound, and then some general words and tactics how to make Egypt safer. Thank you.
Thank you, Professor. And